everyone, I am Megan with the I Believe podcast with Ocular Melanoma, and we have a fabulous guest today. We have Tara McCannel. Hi Tara, thanks for being here.
Thank you so much, Megan. It's a real honor to be part of Ocular Melanoma and to share what I know with you.
We're so excited to have you share what you know with us.
So I can just start, I'll just jump in and just introduce myself and where I come from. So I'm a professor of ophthalmology at the University of California, Los Angeles at the Stein Institute. And I'm the director of ocular oncology and excited that this is actually my 20th year at UCLA. And I've really learned so much about what's involved in helping people who are diagnosed with ocular melanoma, both in treatments, but also helping to disseminate information and sort of really focusing a lot of our academic research on how the more you know about what the ocular melanoma is, why you're getting treated a certain way, and better understanding of the cancer really helps people to do better. So I'm hoping to help further that goal. And I think what Ocular Insight does is really fantastic because it brings all this information together for patients. So I wanted to speak about what's involved in brachytherapy surgery and also just other surgery and procedures that can happen to the eye. And Megan, please interrupt me, just jump in. If there's something that you need me to help explain further, I'd be more than happy to do that. So, we want to have this as casual and easy to understand as possible. When a person gets treated for ocular melanoma, there are really two major categories of treatment, as most of you know. One is removal of the eye, or what we call enucleation, and the other is some sort of treatment to the eye that saves the eye and can save some of the vision. And I'm really pleased that it's actually becoming less common now for patients to need to have enucleation because we are finding ocular melanoma much earlier than we had been even when I started practicing. It's really uncommon to have a person whose cancer has gotten so advanced in the eye that we don't have a lot of options. So I think early detection, getting just eye exams where you're dilated and you're checked, and also a lot of times now when you go to a healthcare office or an eye care provider, you get these photos that are done, and those have been a really excellent screening tool and allow us to find melanoma of the eye when it's very small. So fortunately, it's a smaller percent of the people who have ocular melanoma that need to have the enucleation. And then when we're able to save the eye, which is in most of the cases, the most common way to treat ocular melanoma is using some type of radiation because the radiation destroys the cancer excellently. Without a doubt, I think that's the one thing that we're very certain about with ocular melanoma is that radiation will kill it. And there's a few different types of radiation, but the most common type of radiation treatment is when people have what's called brachytherapy plaque, or when there's seeds of radiation in a carrier, which is like this disc that gets placed on the outside of the eye behind where the tumor is. That's the most common way that radiation is given. A second way that radiation is given is what we call proton beam therapy, and there are far fewer centers that offer this treatment, but it involves radiation, so can be also successful at treating the melanoma. In terms of just talking about what happens in these surgeries, I want to talk about, in terms of enucleation, if a person needs to have enucleation, this can definitely be very traumatic because you're losing an organ. It's like losing a limb, and it's the difficult thing about it is sort of getting over the shock of having to go through this where your eye is taken out. However, I think it's important to understand that if enucleation is required because everything is too big, there's not much vision in the eye, and there's not really anything else we can do, it is far more straightforward and kind of makes a lot more sense than really doing everything possible to try to save the eye, to try to radiate and see if we can keep anything, because enucleation is a very simple surgery. You have an operation that's about an hour. They're able to replace the globe, which is the eyeball, with like a silicone ball that fills the space. After a couple weeks of healing, you can get fitted with a prosthesis that looks incredibly lifelike. And we call this sort of the artificial eye, but really it's like a jumbo contact lens that goes in place. And it's very low maintenance. We have this idea that if you have to have a fake eye, you have to take it out every night and put it by your bedside table. And I don't know where this notion came from, but everybody assumes that that's what's involved. But really, it's very low maintenance. You might only have it removed a couple times a year for polishing and fitting, and then you just leave it in there and carry on. And I've just been impressed with the artistry of the ocularists who actually build and create these prostheses. And I have been at the microscope in the exam room and looking at the artificial eye thinking, whoops, this is the wrong eye, because it's so good. And until you see it under close magnification, you can tell that it's not really the real thing. So very straightforward. And sometimes when people are diagnosed with a really large ocular melanoma, there can also be pain associated with it. And once the eye is removed, all that pain and discomfort immediately goes away. And so it allows you to just carry on and not have this drag on your eye. And I know that sometimes when people have a very large melanoma that is treated with radiation in an attempt to save the eye, sometimes there can be this prolonged period of a lot of discomfort because there's so much tissue that was damaged with the radiation treatment because things were so big. And there can be sort of this ongoing painful period until the person may eventually need a nucleation. So I think if it's recommended that a nucleation is the best hope for getting through this and treatment, it is a very straightforward procedure, and a lot of it is just understanding what's involved.
You're 100% right. Some of the prosthetics look so good, you really cannot tell. And it's really, really impressive.
Yeah, I don't know how the ocularists do the work they do, but basically they take a lot of photos of your other eye and just create this, and it's very difficult to tell if this is your eye or not. And people don't have to walk around wearing a black patch for the rest of their life. I think that's another image that comes to mind. But we have really great ways of helping make people look as they should, as normal as possible after this sort of a procedure.
And the fact that they can match it to your other eye, it's really just, it blows your mind how the artistry and the talent that goes into creating that, but they really are beautiful.
Yeah, I think that's a lovely word. They are beautiful. It's a beautiful work of art. Like the other day, I was taking someone's prosthesis out, and I was looking at it, and when I take them out, I always like wash it first, and then I'm looking at this thing, and I'm like, this is like I'm holding an eye in my hand. It's really amazing. So really excellent work. And some people need a nucleation from the beginning, but sometimes people after treatment and the eye is not doing very well, as I mentioned, sometimes it can be painful and not really giving vision back. If I sort of think that, maybe in the not too distant future, we might be talking about this, I try to bring it up early and just get talking about it so that people can start thinking about this possibility and really adjusting to it a little bit, because it's definitely, it can be a shock if you come to an appointment and you're told that you have to have the eye removed. So just understanding as much about it as possible can really make it a more easy transition if you actually need to have it. I want to talk a bit about what happens in brachytherapy surgery, and certainly people who have already had the treatment may, be already well beyond this. But for people who this is new for, but also people who have had the treatment and maybe didn't quite understand what happened, I think it's helpful to kind of go over what happens in surgery. So I'm gonna talk about the brachytherapy plaque, because that's the most common, and then also a little bit about proton beam after. So one of the things that doesn't happen is the eye gets taken out and put on a surgical table, and we do surgery and then put the eye back. So the eye stays in the head the whole time. It's really possible to do this type of surgery because of isolating the muscles and really getting a lot of exposure during surgery. And when people have brachytherapy plaque surgery, we use anesthesia. I think some centers will do general anesthesia. I know our center, I like to use a lot of local anesthesia. I try to avoid generals unless people are really young or just totally can't tolerate it. But either way, the person is very comfortable, and the surgery can last, it's different at every place, but it can be as short as 30 minutes to sometimes an hour and a half, depending on everything that's happening, depending on the complexity of the surgery. But when you come to surgery, it's usually, in most places now, it's all outpatient. I think that the last I heard, the centers that used to be inpatient, meaning staying in the hospital, have switched. And so most of the time, this is an outpatient procedure. So you don't have to stay in the hospital. And what happens in the surgery is that the plaque, which is customized and built to the specifications of the individual melanoma, the plaque is placed on the eye, on the outside of the eye. And we get to the outside of the eye by opening up the superficial tissues. So we call that the conjunctiva, which is sort of the superficial tissue overlying the white part of the eye. And the muscles of the eye, there's 4 main muscles that we look for, and they're really ones that help the eye look up, look down, and look right to look left. And so each of those 4 muscles is identified at the time of surgery, and we put a suture around those muscles so that we can turn the eye, and you can turn the eye way over so that you can get to the very back. So it's possible to put the brachytherapy, if the melanoma is close to the macula or very posterior, we call that, we can turn the eye and expose that area very well with just using our strings and instruments to help spread the tissues to get right where we need it to be. And because people have anesthesia, you're really not feeling any of this movement around the eye. When we do local anesthesia, when a person is sort of in twilight, we add additional anesthesia around the eye, so the eye is bathed in sort of xylocaine type solutions, which really numbs everything. You can also be sort of semi-awake and you might hear people talking, or sometimes our patients kind of talk along with us, but whatever works. So once we find the muscles, we can turn the eye, and then in order to find where that melanoma is, there's a couple ways, and we use a bit of both, but you can do something called transillumination, which is getting a really strong light and shining it through the dilated pupil, just like if you imagine a pumpkin, like a jack-o'-lantern. If you put a candle inside, if there's something dark on the wall of the pumpkin, it will be black and it will block light. So a melanoma does the same sort of thing. So if you shine a light and you expose the wall of the eye with the light glowing through it, you can see this dark area where the melanoma is. Sometimes melanomas are very tiny, and sometimes they don't have a lot of pigment. So this way of using transillumination, it doesn't always work. So what I always find is helpful together with transillumination is also to actually look. So we put on the indirect ophthalmoscope, which is sort of that miner's light that we use with a lens, and you can actually see where the melanoma is, and you can use what we call a little depressor on the outside of the eye to see and mark where the very edge of it starts. And so then you can mark that on the eye wall. And usually if you do that together with the transillumination, most of the time you're there. But I'm always surprised that sometimes the transillumination isn't exactly accurate, or I mark it all and it looks like I've got it exactly in place. And so many centers also bring their ultrasonographer or do intraoperative ultrasonography. So that's just a third way you can increase the accuracy of the placement. So we always check, and I think most centers now do ultrasound during the surgery, where after everything is in place, we look and say, is everything accurate? Is the plaque, is it lying, are the dimensions usually sort of front to back and from side to side? We usually have 2 major dimensions on ultrasound. We want to make sure that the plaque is centered over the tumor and there's no areas of what we call edge miss, or parts of the tumor that are not being properly covered by the plaque. And I always think it's really important to this is a part that is really critical because we need to make sure that the treatment is as accurate as can be. So we really take our time, we measure, we look, and if it doesn't look quite where we want it to be, or maybe it's a little lopsided, this is the opportunity to move it. So then you can move it, re-sew it, shift, look again by ultrasound. And a lot of centers, in addition to ours, have published on how ultrasound actually can help increase the accuracy of the brachytherapy treatment. And I think ultrasound is really critical. And even though I have all these years of doing this, I don't think I've ever had a time where I thought, I don't need ultrasound anymore, because I'm always surprised that if I do the transillumination, we put it on, it's like, whoa, this was off. So the ultrasound allows you to confirm, but also sometimes there may be a delay from the last ultrasound measurement to the time of surgery. So performing ultrasound also gives you an opportunity to remeasure the melanoma. And if you find that it's grown a little bit, you can give those extra numbers to the physics team. And we usually, in situations like this, we may find that we're adding additional hours or sometimes an additional day to the brachytherapy treatment to make sure that everything is as accurate as can be. So all these things happen. Usually there's a lot of people in the operating room during brachytherapy. We have our radiation physicist, we have our radiation oncologist, in addition to all the technical team. In our case, our ultrasonographer comes in for all the cases, in addition to all the people learning and observing. So it's a very busy, we like to call it's a party in the operating room. So there's lots of people who are watching and learning, and there's usually lots of conversation because people want to understand all the different steps, even outside of the patient, but all the people who are there are usually, there's always people learning and visitors and such. So once everything is in place, then we can put everything back, and the plaque remains sutured onto the eye. And there's different ways to suture the plaque, but we do use stitches that hold the edge of the plaque against the sclera, which is the white non-vascular part of the eye where we sew things to. It's just this, in a similar type of surgery where we do in retinal diseases, doing retinal detachment surgery. I also do surgical retina, and if people have retinal detachments, we often use a scleral buckle. So sewing things onto the sclera is not an unusual or rare thing. So putting on a plaque and sewing that on is something very doable. We have sutures that are very good for that. One of the things that we do is we sew our plaques on a way that we can remove them in the office. So there's different ways to do that. I think most people will come back for a second surgery that's usually much shorter, just to remove the plaque.
It's so fascinating. It's just amazing what modern medicine is doing. It really is. I think the question I have right now is, after you stitch the plaque on the eye and they go home, can they feel that in there?
That's a great question. So the further back the plaque is, so the more posterior the melanoma is, there's nothing really to feel or even see back there. And often there's not just the eye, and there's so much soft tissue in the orbit, which is like the eye socket where the eyeball sits. And because things are being moved and turned, there's a lot of swelling in all the tissues in the eye. So we often give people a little bit of steroid during the surgery just to help that swelling go down and not be so tense afterwards. Sometimes when everything's very swollen, it can be very painful as well. If people feel anything, it's really just the bit of swelling and a little bit of inflammation after the surgery. The funny thing is, even if the plaque is at the very front of the eye, and sometimes if you have like a tumor that involves the ciliary body, which is towards the very front of the eye, you can see, oftentimes you'll see some of the gold from the front. With the eye open, you'll see a gold part of the plaque showing. And it's really quite amazing that doesn't cause additional discomfort. And even sometimes we have our plaques hanging over the cornea, which is the front of the eye, which is a very, very sensitive structure. As long as everything is still and in place, there really isn't any discomfort from that. And so actually, I don't think people really feel the plaque at all. They may feel some swelling or just all the tissues being a little bit altered. But no one has said, oh, I feel the edge and it's actually correlates. We really amazingly don't feel the plaque on the eye.
That is amazing because you get a tiny little eyelash in there and it drives you crazy. But the fact that you guys can put a whole plaque in there and they don't feel it really blows your mind.
I think it's just because different parts of the eye have different sensitivity and different innervation, and the cornea being the most exposed part it's like one of the most sensitive places with the densest nerve receptors in the body, so that, I mean, for our protection. So if anything touches the eye, it's going to affect our vision, so we react, in a very hyper reactive way. So like an eyelash, exactly as you say. Even sometimes with the stitches, some people feel the stitches afterwards, but I feel like there's a lot of times I'm really amazed that even if there's little strings hanging that are about to dissolve, it really just is part of the eye. But, it also, there's little details too. So there's different types of suture material, and suture material that is more sort of what we call hydrophilic or sort of water loving. Those tend to be less noticeable, as opposed to certain types of stitches that are cause more irritation. So there definitely can be variations in materials that people use in surgery, but the plaque itself usually is not felt. And really for that week that the plaque is in place, it's normal to have some discharge coming out of the eye, like tearing, and it's normal to kind of look in the mirror and see everything is totally swollen, like you were in a fight, and everything looking red. But all that, once that week is over and the plaque is out, everything heals very quickly, like within a matter of even a couple of weeks later. When you look at the surface of the eye under the microscope, you can't even see where those incisions in the conjunctiva were. You can see the tissue is irregular because it's healing, but the healing happens very quickly. But it definitely can feel like a very prolonged, uncomfortable, not so much in the sense of being painful, but just everything being so out of sorts, and the swelling and looking red and feeling bumpy. That's all very normal. What isn't normal, though, is if you have a lot of pain, like if it feels very painful, especially if you have pain that develops during the few days that the plaque is in place that wasn't there before. If you notice anything that seems unusual or uncomfortable, always call your ophthalmologist. Don't just kind of wait. And if pain that develops during the treatment period needs to be reported. It's possible, what are the reasons that we want to watch out for? You could be developing high pressure in the eye. You could be developing an infection, although very uncommon, but still, it happens. So if you have any unusual pain, always call. It's better to be safe than sorry. And another thing that we find is sometimes people take photos with their phone of what it looks like, and they say, is this normal? Or there's a string I see here, should I be concerned? So I always encourage people to sort of engage with your ophthalmologist, like reach out to the team, like ask questions. You don't want to be kind of worrying during that week. And pain, in terms of it's normal to be uncomfortable, but that should, even as the time goes by, should ease or remain stable. And soon as the plaque comes out, with each passing day, it should start to feel better and better. So if anything doesn't quite fit that, or you're not sure, always call. I can't stress that enough. There's always someone available to answer questions at major centers, and so definitely use them. That's why we have all the people that we do, so that we can help people and bring people in if there's any reason to double check something during the treatment. And then while the plaque is in place, often I find that sometimes people think that, when the plaque comes out, that melanoma is going to be gone. So what actually happens is the radiation destroys the DNA in the melanoma tissue. It destroys the DNA in anything in its path, but because cancer cells are more rapidly dividing, their DNA is more sensitive, and so those cancer cells are very prone to, and they're very responsive to the radiation treatment. But right when the plaque comes out, things generally look about the same. You really can't tell much difference in just a few days. However, Oftentimes, by about a month afterwards, the tumor can start looking different. One thing to point out is that depending on how big your tumor is to start with, that will determine how much change we see. So a person who has a very large melanoma will see a lot of changes faster in the recovery period. If you start off with a really tiny melanoma, we might not see very much right after the treatment, and it might take several visits to actually see reduction in leaking or even a little shriveling. So the smaller something is, the longer it's going to take to see much difference. But the bigger it is, the faster we see response. And so that's something to keep in mind, because I know that it's normal when you get checked afterwards to kind of be hoping that I hope that it's shrunken, I hope that it's gone. But one thing to point out is that really whether if it's decreased in size or about the same size, that's kind of the same in terms of the ocular oncologist perspective. When we're looking, if it doesn't shrink a little bit, it doesn't matter one way or the other to us. So we don't feel bad at all. So I want to point out that that's not necessarily like bad news if we don't see shrinkage. I mean, and even years after follow-up, we might see some reduction, and then it's the same measurements for a lot of time, then might get a little smaller. But as long as it's responded from its original state, we're ahead. Most times, most centers do anywhere from 4 to 7 days of a brachytherapy treatment. And, the question, we see a lot of people for second opinions, and people are wondering, why do I have to have X number of days versus another? Well, it usually is just based on logistics. And for example, the ocular surgeon might put the plaque in on a Monday, and it's convenient to take it out on a Friday. At our center, we always plan for 7-day plaques, just so that we come back to the day that I have assigned to me to do surgery at our center. And just because we have a lot of number of days doesn't mean we have any more radiation. So what the physicists do is they determine how much radiation is needed to kill a melanoma of that size, and then they look at the amount of time that they have to have the radiation be released. And so when you have a longer number of days, usually the radiation release is slower. If you're only, say, putting it in for 3 days, then our physicists like to call that like a very hot plaque, because there's much more radiation coming out, because all of it has to come out in 3 days. So it really just depends on planning. The amount of radiation that is used is really based on the tumor dimensions that the radiation team get when they construct the plaque. And sometimes, I mentioned before that some ultrasound can help give more information during the surgery. For example, a larger size melanoma, we always remeasure them, because the bigger the tumor is, like the more cancer cells there are, so the higher the likelihood that it can increase in size. If you have a delay in treatment, like if it's, say that you're supposed to go but you were delayed a couple of weeks, so really confirming the measurement at the time of surgery is really important, because if we add extra days, it's to help make sure we get the treatment. And then there's another reason sometimes we add a day or so, is because when we look at it by ultrasound, sometimes these brachytherapy plaques, they don't fit perfectly around the roundness of the eye. And sometimes when you see by ultrasound, you can see that the plaque might be a little bit away from the eye wall. And so what we do is we measure that space and recalculate, because we don't want to undertreat just because the plaque is a little bit away from the eye wall. And the reason for this is because there's a lot of tissues in the eye space, and especially when the tumors are very posterior at the back of the eye, or they're very tiny. Sometimes on ultrasound we can see some tissue between the plaque and the eye wall, and even if you go and try to move the tissue, sometimes you just can't. Nothing really moves depending on where it is. So we just recalculate the treatment. So a lot of adjustments can happen to the treatment plan at the time of surgery. And it's important to kind of look for things and allow for being flexible if it's going to result in better treatment.
So while they have it on, whether it's 4 days or 7 days or whatever, what can they expect? Like, are they going to feel nauseous? Are they allowed to drive? Do they need a special diet? Like, what's that time with the patch on going to look like?
Yeah, that's a great question. So we generally recommend, well, first of all, I'm going to just go real basic. So our physicists recommend that people don't go into crowds of people. And I always say if you're around people or pets, just wear the lead shield. And we often provide, most centers provide, it's literally like a pirate patch with a lead on it to reduce or to really to prevent any extraneous radiation from coming around. And it's important to keep in mind that the eyeball is so small. A melanoma, even the size of tumors is very relative, but relative to the whole body, very tiny. So the amount of radiation that even can be detected close to a person with the brachytherapy plaque, even treating a large tumor, is very low. But because like most physics and radiation oncology departments, we recommend just the same protocols, whether you're having, whatever the organ is. So they always recommend wearing the lead, being a certain amount of distance away from people. But I just sort of simplify it to if people are around you, put it on. If you're by yourself, have it open. And just try to minimize that, but not to be alarmed if suddenly your family member is sitting on your lap and whoops, we forgot about that. You can just, nothing untoward is going to happen. And we've never heard of a case of someone developing a problem with a partner or somebody getting exposed, but we just do it for safety. Most people feel nauseous. If people feel nauseous the day after surgery, it's, in my experience, it's usually the anesthesia that's wearing off. And I find that, when we're checking people the first day after surgery, not a lot of people, but some people, especially younger people, young men, tend to be kind of not like they're kind of passing out or not feeling good. It's a lot of it is the anesthetic that is still in the system. And that usually passes after about a day. So I would tell people to be just, don't, and in terms of diet and what you should eat, don't rush anything, because if you're kind of a little bit on a roller coaster in terms of nausea, not feeling great the very next day after surgery, you want to take it easy. So go, people have been sort of, no food or drink before midnight, and people haven't been eating up until the surgery. So go really slow, lots of fluids. Don't rush into a big meal right after the surgery. Just go slowly and sort of build up your appetite. Wait till you really have a strong appetite, because it's not unusual to feel a bit off after you have a procedure. And much of it isn't, as I said, it's mainly the anesthetic. It's not necessarily the, manipulating the eye itself. Although some people, if you feel really nauseous or unwell, we have to make sure that the eye is doing okay. And that's why we check people the day after surgery to check the intraocular pressure. Now, sometimes the pressure can go up just having surgery, so we want to make sure if that is the case that we treat it during the postoperative period. Usually with each passing day, the person should feel a little bit more comfortable, and the swelling will get less. And I encourage, if the eye is so swollen that it can't even move when the patch comes off and it's being checked, that a person do a short course of steroids, like a Medrol dose pack, because the pain when tissues are swollen can be excruciating, and it's very safe to have something to get you to feel okay afterwards. We use Medrol intravenously during our operations, and like a colleague of mine was doing this for scleral buckles, and I started doing it, I don't know, maybe 12 years ago, and it's day and night. We used to have so much trouble taking the patch off because people were so sore because of the swelling, and now people walk in like nothing's happened. So it really makes a difference. So really kind of, there's little things you can do. And I also tell people to use a lot of ice. So the swelling can be, if it's a lot of inflammatory swelling. So if you have like ice chips or frozen peas in a bag, put it in a Ziploc bag and just hold it over your eye, that'll really help with the swelling. And if you do a lot of icing of the eye, you will probably need to use less Tylenol or Advil. And I recommend everybody use Tylenol and Advil if they're uncomfortable. We have not had to use narcotics for many years now. And so there are measures that you can do to help alleviate this sort of postoperative pain and discomfort.
I think the last part of it would be, what's their activity level? Should they be kind of laying low, not driving, or can they do anything?
Yeah, that's a great question. So, I tell people to just, if you're feeling well, just go back and do your physical activities. There's really no reason to kind of rest and lay in bed and really chill out. I find that the more people kind of get back to doing things, moving around their home or, doing light exercise, the people recover much better. It's nowadays, especially, we used to do a lot more positioning in retinal surgery, have people be face down for 2 weeks, or do even, way back when people had to be inpatients to have cataract surgery. We've really moved away from that. Now people don't even position a lot of times for retinal surgery. And so it's really important to get people feeling good as soon as possible and doing things that they feel comfortable. I tell people, if something you're doing makes you feel uncomfortable, like even you mentioned driving, technically you can drive legally, but it's really a matter of comfort. So once you're comfortable moving around your home, it is probably it's safe to go very short distances if you want to. If you're feeling unwell or not good, or you feel off because your eye is really blurry, then definitely have people help you. And wait till you feel comfortable before venturing back into all the regular activities. But in general, I recommend people don't lay low for that week. It's just important to stay active. I have some people, if you feel really great the day the plaque comes off, then you can go for a walk or, do some light exercise. It's just really important to just keep yourself moving and not completely kind of regress into it, because then you have to kind of climb out of that afterwards. And it's just so much better for your overall wellness and just feeling good about things to be a little more active. The main difference with brachytherapy and proton therapy is that in brachytherapy, the radiation comes from the plaque sort of behind the eye wall to the tumor, which is on the eye wall. In proton beam therapy or any kind of external radiation therapy, the radiation comes through the front of the eye and then culminates at the tumor to treat the tumor. So proton therapy involves, and I used to, in my training, my training was at the Massachusetts Eye and Ear Infirmary at Harvard Medical School, and we had the Northeast Proton Beam Center, where when I was a fellow in training, we spent a lot of time with people who are having proton beam and kind of going through everything. So it's like yesterday, so people, you still need to have a surgery to mark the borders of the tumor. And in brachytherapy surgery, you have the surgery, you find the tumor, you put the plaque in place. For proton therapy, you have a surgery, you find the tumor, and you put markers at the edge of the tumor. And these markers can be detected on x-rays that they use at the proton beam. So you have a surgery to put markers, and usually 1 or 2 weeks later, then you go for your sessions at the proton beam facility. And usually it's like 5 consecutive days, where each treatment may be about a minute, very short. But during those radiation treatments, you're awake. We don't use anesthesia for the actual radiation sessions. We do for the surgical part, but for the radiation sessions, it's important that you are very, very still, because if you move or blink or move around, then the path of the radiation isn't as accurate. So in order to do that, to prepare for the radiation sessions, most places will create sort of a frame for your face, which includes, certainly at the Northeast Proton Beam Center, there was a bite block you sort of clench your teeth around so you could hold your face really, really still, and there was something light or an indicator that you would look at to keep your gaze steady. And then there would be somebody monitoring, and certainly at the center I trained at, it was the fellows, so we would help the patients open the eyelids, and we would monitor that the eye was exactly centered, and people were not sort of wandering. If a person started to drift, we turned off we were able to stop the treatment and then kind of get things on track again. And sometimes it can be difficult. So we'd have to kind of stop and make sure that people knew what they should be looking straight at. But certainly the centers that have a lot of experience with proton beam, they're really good at making sure that everything's in place. And, I remember the radiation team was incredibly excellent. Everybody knew how to just get things just right. So there's a series of treatments. And so the end of about, say, it's usually that I'm familiar with about 5 sessions, that would be the end of the radiation treatment. And then the same monitoring happens. We see you afterwards. Then we start doing ultrasounds to confirm that there's been good treatment response. So proton beam therapy is very good at destroying melanoma, no question. And I think that most centers, the interesting thing that I've learned over the years is that everybody does things a little bit different. And when I visit colleagues and see what they're doing, I learn that there's different, people use slightly different techniques. People even measure for the brachytherapy plaque slightly differently. It's just amazing the amount of variation that can happen, that's involved in this. Some people really like to take muscles off. I don't like to take muscles off because it's just extra stuff. And I don't, that's another thing I'll mention, that sometimes in order to put the brachytherapy plaque in place, a muscle may have to be moved in order to position the plaque. I find that when muscles are on the eye, it really helps exposure because you need the muscles to turn the eye. If the eye has no muscles, you're just kind of like, it's hard to just move the eyeball, but the muscles are kind of like the handles that help expose and allow tissues in place. But when we do have to move a muscle, usually if I have to sew right where the muscle is and I can't get the plaque there, what happens is each muscle of each of the 4 eye muscles is attached sort of at what we call the equator of the eye, which is just past where you can see it in the eye socket. And so you find where it's attached and you use scissors to snip the attachment, but you sew the ends in place. And there's many different ways to sort of what we call disinsert the muscle and then put it back. I like to leave the stitch in place. So when the plaque comes out, I just pull it back and tie it, and then the muscle's back in its place. And what we found, and certainly when we've looked at our cases who people need to have the muscles moved, disinserting a muscle does not have any effect on double vision afterwards. Double vision is more sort of the location of the tumor, usually more in the posterior part of the eye. But if you have to have a muscle removed, it's a very, very safe type of a procedure to help facilitate the surgery.
You mentioned putting markers in the eye. What does that mean? Like, are you actually putting something in, or are you just marking? Do you have to take it back out? What is that?
Oh, yes, thank you. I didn't speak completely about this. So we use, for proton beam markers, we actually sew what's called tantalum clips, and they're like little metal. They're like metal, it's like a little these little fasteners, like, the back of a dress has that extra fastener. It's a little tiny thing like that you sew on with like a circle in it that you just sew it in place. And they're radio opaque, so that when you are doing the proton beam treatment, you can actually see the markers, and you line up the markers to line up the proton beam. And that's why, and they stay there forever, actually. They never have to come out. They will never set off. Like, you can have an MRI, they don't cause trouble, they don't set off metal detectors. And it's just the nature of that. It's called tantalum. And that's sort of from what I understand, is the universal material that is used to the markers to put them in place. And you don't feel them afterwards. I don't think I've ever heard of a case of them coming out, but it's possible that they could just work themselves out, but that's very uncommon. And they don't change, they're inert, so they don't really cause any trouble or additional inflammation of the eye. And the eye can have ultrasounds and really just, very, very usual activity afterwards. And we leave those markers, or we call them clips. They stay in place forever.
And you won't set off a metal detector or anything like that. You just go about your life.
Yeah, but I should mention, when you mentioned metal detectors and going through like TSA, so if you happen to have a radioactive plaque on your eye, you will set off TSA alarms. So if you're planning to fly in that period where the plaque is on the eye, make sure you have a letter from maybe the physicist or somebody. Make sure you have a letter because it will. So we have patients who fly in who are not too far, so they'll fly like from Nevada, they'll fly back home or they'll drive. And we recommend most people stay nearby just for that time, just because most people don't want to be far away. But occasionally we've had that happen in the past. So just beware, be prepared so that you can make your flight.
So I'm sure this is a very complicated question, so feel free to make this as simple as you need to. But how do you decide which one to do? How do you know what's the best choice for somebody? Or do they have a say in it, or do you kind of tell them which one?
Yeah, that's a great question. And the truth is, what the treatment that is going to be recommended to a patient is going to be what the center does. And I can think of one center that does, maybe two centers that do both brachytherapy and proton beam, but most places do exclusively one or the other. And so it's, many times people find themselves referred to a particular ocular oncologist and they have what's recommended. But also we have people who have researched each of the centers all across the country and are visiting proton beam centers and talking to people. So, it's variable. And I have my own view of it. Prior to coming to UCLA, I did all my training at Massachusetts Eye and Ear Infirmary, and all they had was proton beam. And I was convinced that we had to get a proton particle accelerator at UCLA in order to treat melanoma because I was so impressed with the results and et cetera. Then when I came to UCLA, which had been doing brachytherapy plaques for long before I was there, I was, okay, fine, we'll do plaques, but we need to think about getting a proton beam set up at some point. So, but after a while, I love doing brachytherapy plaques, and I just think it's such a elegant way and a relatively simple way to treat the problem. We don't need a big particle accelerator, and the side effect profiles are slightly different between the two treatments. In addition, I think it's you really want to. The most important thing that matters, that number one, is accuracy. So if you look there's not a lot of proton beam centers, actually. The vast majority of places that treat ocular melanoma do brachytherapy plaque. So among the few centers that do proton beam, what I've learned from my colleagues who do proton beam and also colleagues in Europe there's some centers, major centers there that do proton beam, is that each proton beam is different. It's collimated differently, it's calibrated differently, and so they all work a little differently. I think that there's less uniformity. So it's important, if you're going to a proton beam center, that you can ask about what are the success rates, what is your recurrence rate, and all sorts of things. These are things people should ask anybody, actually. What is and not just what is the success rate, but what is your success rate? Because every center has a different rate of success and there's so many details that go into this, but with proton beam, there's a little more variability. And I think a center, I'm biased to my old training center, but the Northeast Proton Beam Center, they had phenomenal success rates. They were very good about publishing. They published their data over many decades, like starting in the 70s. Their success rate is very high for their treatment, and so they have a well-oiled machine. I think there's other places that are sort of thinking of introducing proton beam, but there's so many details. So I think part of when you get diagnosed and you're learning about the treatment options is you first of all talk to the person that you're in front of first and find out what do they do, what are they recommended, what do they think about proton beam, and if it was their eye, what would they want to be doing. I know for using brachytherapy allows, at UCLA we place silicone oil in the eye, which helps minimize the radiation to healthy tissues, and that can only be done with brachytherapy because you can't if you put silicone oil in the eye and do proton, you'll affect the radiation going to the tumor. So it doesn't really work with proton. Proton beam therapy has, it's been published, but there's a little bit more eyelash issues, more dry eye with proton therapy. But again, you need to ask the center that you're at and find out, what should I expect? I know there's a proton beam center in Northern California that a lot of different people use, and so it all depends on the details. So I think most of the time we don't have a choice. Like you asked, can I choose what I want? I think in order to make a choice, you have to understand what would be the pros and cons. What would be the advantage of doing this versus that? Or, should I go to a center that has a proton beam? Should I go to a center where there's brachytherapy? And I think the most important thing is to go to a place that has a lot of experience in what they do and have them share what their experience is, and then ask what the opinion is of your doctor. I feel like so many of my colleagues do slightly different things, but they're all very excellent, and you just want to do the due diligence, do your research, find out what is done. I think brachytherapy is pretty tried and true. As I said before, all radiation treatment will kill the melanoma. And if you are in the position to get a few opinions or to choose, then definitely do the research, learn about as much as you can, understand the differences. And if there is literature kind of loosely comparing the two types of treatment and the comparisons. I think we published a paper a long time ago looking at all the data in the two treatments, and they work similarly, but you really have to ask very pointed questions to your oncologist. There's no such thing as the only way to treat something, and even among centers that use the same treatments, there can be differences. So it's a hard question to answer, but I think that the most important thing is you get the treatment. And when you're getting opinions and doing research and learning about all the different options, I always tell people, don't take too much time. Really do it in as quick a time as you can, and then ask your ocular oncologist to help give you suggestions for second opinions. You don't feel bad about saying, "Oh, can you give me 2 or 3 people that I could see as second opinions so that I can learn more information about my choices?" That would be my advice.
I think that's really smart too, and don't be afraid of offending your doctor. I think that they want you to get second opinions, and that's such a normal thing, but people are sometimes maybe a little afraid too because they don't want to offend anybody. And I think you need to put you first and understand that they know you're going to get a second opinion and they're not going to be offended. And if they are offended, maybe that's not even the right doctor for you.
I 100% agree. If your doctor looks at you like, why would you get a second opinion after I've told you what I said? I mean, that's not the attitude of someone you want looking after you. I'm just going to say it. If someone gives you a hard time with second opinion, then just turn around and find somebody else. You need someone who's going to be responsive and understand why you have questions, and someone who you can work with. Today, maybe 25 years ago, we wouldn't really know how to get the knowledge, but there's so much good information available now that it really is, the responsibility is on patients to question their doctors. You don't have to go to the person that you were referred to. You can, there are not a lot of ocular oncologists, but sometimes you might have options. Maybe there's like 1 or 2 or 3 people in an area that you can go to. And even if you like your ocular oncologist and you're thinking you're probably going to go there, you can certainly get a second opinion just to learn more. You can get a second opinion and just decide to stick with the first one. It's not like you're leaving your doctor. And again, doctors, I think we're becoming better at making this normal, getting in second opinions. But I do know it's still hard for some physicians to be open-minded about second opinions, but that's just too bad. They're going to have to learn because, it's all about the patient and what you feel comfortable about. And really just, even if you belong to a health plan that might have a limited limited options, oftentimes you can ask for a second opinion, even if you have health insurance where only a particular ocular oncologist is in network. So ask. The worst that can happen is they can just say no, but you definitely can ask and say, this is a rare condition. Few people have experience in this, and I feel that because I have this rare condition, I need to be approved for a second opinion at Center X. So definitely you have a lot of leeway, especially if this is rare. If this is extremely common, then there's usually a lot more providers, but this is a case where in ocular melanoma, it's very important to get a second opinion.
And you need to be with a provider that you trust, and that relationship is important. So even if you think that you do agree with what they're saying, if you don't feel that connection, it might be worth exploring another doctor just to find somebody that is a good fit for you.
Yeah, I think that's so true. And you're never going to regret getting a second opinion unless you took a really long time to get it. And by really, don't do all your opinions within, the majority of people have about 2 to 4 weeks. This isn't something you have to treat tomorrow. This is, there's usually time with ocular melanoma. We don't want to leave it a long time, and obviously each case is a little different. Some people we have to go faster than others, but the majority of people we have some leeway so that you don't have to rush into anything.
Yeah, I think that's really important.
Let me think about other aspects of treatment. I think that one of the things that people often wonder about is, after the treatment and having the surgery and procedures, people want to know what happens after. What do I need to have more radiation? I'm going to have additional treatments, and usually the answer is no. It's usually one surgery, one radiation. But it's important to still do the evaluations and I really strongly recommend that people stay with their ocular oncologist if they can, because we have seen 9 years later, someone can start to get a recurrence. And if no one was really looking for that, it would have just sort of gone out of control. But if you find something like a recurrence later that's very small and very treatable in an eye with good vision, you can have a second brachytherapy plaque. It's becoming pretty normal now. In the olden days, we used to say, if the tumor comes back, we have to take out the eye. But we would take out the eye if there was really no vision. But if there's vision and it's very treatable, it's what I've learned is that the eye does not completely fall apart with a second dose of radiation. There's this notion still. I remember the very first time I remember doing a second plaque, our radiation team was like, well, we can't do that. I said, well, what's the option? We're going to take the eye out. So everyone was very surprised that the patient tolerated it very well. And, now when we do see a recurrence and the vision is good, most people tend to maintain their vision. So a second dose of radiation is not necessarily a vision-threatening sentence. So, make sure you get followed up, make sure you monitor the eye. And the other thing when you're getting these eye evaluations, don't just focus on the melanoma eye, but make sure that the ophthalmologist is looking carefully at your other eye, because there are so many conditions of the eye that are far more common than ocular melanoma that are so treatable. And, number one is cataract, and then glaucoma. And then there's a host of various retinal conditions. But even just because your eye had a melanoma in it, and if you develop like a macular hole or something different, you can have the treatment that everybody else has. Sometimes I hear that, oh, this is a melanoma eye, don't touch it, just leave it, it's been through a lot. But if there's a way to make your vision better, because that eye has a condition that is more common and that we know how to fix, then you should definitely have surgery. And the other thing is, cataract. I often find people saying, oh, my doctor told me that I should wait as long as possible to have cataract in my good eye and maybe never have cataract surgery, because what if something happened to my good eye? And I just think I would flip it around and say that in order for you to function well, if you do start to have a vision degrading condition that's happening in your better eye, you need to be all the more proactive about getting it treated so that you can continue and do well. Because cataract is such a such a common and highly successful surgery that to sort of not to deny people to have cataract surgery just because there might be a remote risk that something might happen is just not appropriate, in my opinion. And I think it's really outdated to tell people not to have surgery that we're so good at because of this rare risk. And I try to talk to people about it. And there's people who just don't want anything done. And, you know, it's completely your choice, but it's important not to necessarily have the fears of your ophthalmology team, you know, trickle onto you if it's going to result in impaired vision. So there's a lot of things that you can do. And the other thing I mentioned is glaucoma. There's about 8 to 9% of everybody who gets a brachytherapy plaque will develop a pressure issue with their eye down the road at some point. And I find that a lot of people are scared to treat glaucoma in a melanoma eye. And unfortunately, I've seen people who've lost a lot of vision because their ophthalmologist was too afraid to do the standard glaucoma surgeries in a melanoma eye. And I think that's just really unfortunate. But, you know, again, if when I see people regularly, I always ask about what else is happening in their eye care, who's checking this, who's doing that. And sometimes I have to get on the phone and call their ophthalmologist and say, hey, you know, it's completely safe. This tumor is dead. You know, please do, you know, glaucoma surgery so that the vision, we're not going to lose vision from something else. So I encourage people to, you know, ask questions not just about the cancer part, but about everything in their eye health.
Yeah, I mean, that makes sense. You want to preserve any vision you have. So yeah, I mean, I think that that's wonderful that everything is progressing the way it is and they're starting to see that they can save the vision. I mean, that's the ultimate thing is, you know, obviously getting the cancer to be, what's the word? Not cure.
Kill the melanoma.
Thank you.
Just kill it. I don't, there's no fancy words.
What's the right word there?
We want that dead.
Yes, to kill the cancer, but then we also need to preserve quality of life and vision. And so you don't just want to stop there. So I think that's great. And that, you know, technology is progressing enough that they can do more and more. It's really just fascinating. And I mean, what a time to be alive. Like the technology is just exploding.
Yeah. And then there's so much happening in, you know, repair of, I mean, I think in the field of retinal detachment even, and sometimes eyes with a melanoma might, after treatment, sometimes you can get a retinal detachment. And I find that a lot of times doctors don't really want to treat it. And that really bugs me because we know how to fix retinas. And so if you find that, you know, your vision is down and you're asking, why am I not seeing? And then you hear that there's a retinal detachment, you can say, well, how about we fix the retina? Because, you know, people do that. That's a normal thing. And I find that people are always reluctant to do that. So I encourage people to, you know, ask specifically, like, why is my vision decreased, if it is, or why am I seeing this? And once you understand what it is, like, ask, what are we going to do about it? You know, are we going to just leave it there? Or, you know, do I have to live with this, or can this be fixed? And I find that there has to be a lot of work amongst the ophthalmology community to let people know. And you know, a lot of times I give talks in our annual meetings and things about all the different things that we have to make better vision in ocular melanoma eyes, because we have so many incredible techniques. As you say, there are so many advances. It doesn't have to be an advancement in eye cancer, but an advancement in any type of eye care is translatable to an eye with a melanoma. You know, there's so much that people can benefit from, but I often find that it's hard to get the eye doctors to be open about it, because I feel that, honestly, you know, an eye with a melanoma is a little second-class citizen eye, and we have to just let people know that we have to fix that. If you have macular degeneration, you get macular degeneration in an eye with a melanoma, we'll treat that. You know, we're not just going to leave it, of course. I mean, we have, like, that. I think that's the area we have the incredible progress in the last few years, is the treatments we have for age-related macular degeneration, where we can improve vision, and people are driving as they get older with these diseases. I mean, these diseases are fairly common, and they can happen if you have a melanoma, and you got to get that treated. And so just, you know, I think a lot of it is just for the audience is to ask questions. If something is changing in your vision, you want to know why. if something is a little worse, your ophthalmologist needs to tell you why and what you're going to do about it, if you can. Because yes, there are some things we don't have treatments for, but there are so many things that are treatable. So if you have a treatable condition, you have to push to get the treatment. And if your doctor is reluctant, again, get a second opinion. See someone who has the ability and willingness to help you see your best. And that's really what it's all about, as you say. It's just really, making use of all the advances that we have and making sure that they apply to your eye health.
And we talk a lot about advocating for yourself, that you're your best advocate. And this is one of those situations where if you don't go ask those questions and you don't advocate for yourself, no one else is going to do it.
That's absolutely right. Yeah. And you have to feel really comfortable doing that. You have to think this is for you. This is, it's your eye and your life, and you have to be comfortable just speaking up for yourself and talk to people. I always recommend people bring somebody to their appointment, because even I've been a patient before, and I often find that when something is happening to you, you kind of lose a little bit, you lose your voice a little bit. So bring someone with you, a good friend, a family member, a partner, and have them there together with you to make sure that you got through all the questions on your list, or that the person coming with you is, you got two sets of brains there that are analyzing the information you're getting, and they can ask questions too. So I think that's very helpful, because sometimes if you're just by yourself, you might not feel strong enough, but when you have someone with you, I would find that if I ever come with someone to a medical examination, I'm right there ready to interrogate and find out everything. So bring a close friend. I think that's the tip I'd recommend.
Yeah, and even if they can't go in person, you can always put them on FaceTime on your phone and have them
Exactly.
right there with you on your phone.
Exactly. That's a great thing too. Bring people by FaceTime and in person. It's, there's so much you can do. And I encourage everyone to try to do the most they can to really engage. It's all about your eye and your health, and so much people can do in this experience. Not only in the very beginning, but even like a decade later, if there's more information or more knowledge, I find that it really is important for people to keep learning, even if you think you're old hat. I mean, there's always something else.
Right. No, absolutely. That's 100% true.
I think a lot of people, like, it's really hard to get that kind of information in your eye appointments. Yet I feel like there's little pieces that I talk to people about, but just sort of really focusing on all the things you can do, like literally like mind and body and physical health and so many things that relate to people doing better. So I so appreciate that. I just really, am excited to reach out to people and be a resource. And I'm happy to, if a topic comes up that you need any help on or I can speak about, please don't hesitate to ask me. I feel like I really want to share everything that I've learned and what I think would help people who are going through this, just to do just to make this something really, like an opportunity to sort of learn new things and to just, really engage. I think that's really my mission. I feel it's important that we do all we can. And I mean, I've just been in this so long, I feel like I need to figure out a way to share as much as possible. I so appreciate it, Megan.
Thank you all so much for tuning in, and thank you to Dr. McCannel for all of your great information. We've loved having you and all of this great information. I know it's going to really benefit our entire OM community.
Thank you so much. It's a really honor to speak, and I really appreciate the opportunity.
Absolutely. Hopefully we'll have you back soon. And we just want to thank our sponsors, Castle Bioscience, for helping make this podcast possible, and to all of our viewers for watching, liking, subscribing. Everything that you're doing is also making this possible. So if you've not subscribed to our YouTube channel, please do that. You can also follow us on Apple, Spotify, anywhere that you get your podcasts, and please follow our social media as well. You can also sign up for our newsletter at acureInsight.org. There's a little button at the top to get the newsletter, and then we'll send you some great information every month and keep you in the loop on all the things that are going on in the community.